So, I think, although people is taking coffee, I will call immediately, and because the theme is quite interesting, I would call for Francisco Pina. Francisco Pina is a well-known urologist from the north. He comes from Centro Hospitalar São João, and his main interest area is on oncologic urology. So he's going to talk us about a very interesting theme, which is, and a very difficult one, when not to treat and wait. So that's quite difficult for us because we are physicians and we like to treat patients. So Francisco, it's a pleasure to have you here, and let's hear what you have to tell us, please.
Thank you for your nice words and for all the table. Thank you for Dr. Caleda Silva, especially because when he invited me to talk about this theme, he put me in front of 400 papers that came out during 2017. So, we are now going to travel for very different waters. We are now traveling to prostate cancer with very low risk or with low risk. One of the interesting papers that came out is, several ones were, they make very interesting observations on the temporal trends in treatment in the United States. This database goes for almost 600,000 prostate cancer patients. And what we can see is that between, between 2004 and 2012-13, the observation for low-risk prostate cancer rises from 9% to 21 and 27% now in 2013. Radical prostatectomy also increased from 2004 until 2012. External radiotherapy and brachytherapy goes down. For intermediate risk prostate cancer, there is a very similar pattern that I don't put here. So what is interesting when they use a multivariate analysis is that racial minorities, uninsured patients, low-income patients, old patients, community cancer center patients, and very low-volume facility treatment centers, those kind of minorities are much less likely to receive prostatectomy, radical prostatectomy. If we go to see another national database, now from Sweden, with 32,500 prostate cancer patients, we also can see that active surveillance rises from 2009 to 2014, almost arriving more than 9% of the patients. The same for younger patients. If we look to low risk, this is very low risk. Low risk patients rise from 40% to 74%. So we found here two very large databases, one from the United States, another from Sweden, with very interesting temporal trends. Well, we are able to look at trials that compared watchful waiting with radical prostatectomy, and we have two big trials. One is the PIVOT trial that now has 12.7 years of median follow-up, with half of their patients with digital examination positive for cancer in 50% of the patients. And this trial did not find significant differences in all cause of death, in death attributed to prostate cancer, but it found something interesting, lower in almost 15% of patients of death attributed to intermediate risk of prostate cancer, and significantly less presence of bone metastasis and disease progression. So, if we look at this very interesting paper from Dallela, published in the European Urology, they looked for the National Cancer Database from the United States, which represents 70% of newly diagnosed prostate cancers in this period, and they found that the national population of those cancers is completely different from the population that was used in the pivot trial, either in the mean age, either in the comorbidity index, either in the rate of d'Amico low-risk prostate cancer. And they conclude very interestingly that the conclusions from private trial are not probably applied to the contemporary United States population from now, and that he has also a limited statistical power to detect those significant differences that came out in the paper. If we go to the other trial, the European trial in Sweden and in the other countries around, the Scandinavian Prostate Cancer Group Study 4, this database of this trial is not quite similar to the database of the pivot trial, because in this case we have almost 90% of digital rectal detected prostate cancers. And they also compared watchful waiting with the radical prostatectomy. The median follow-up is now, for those series, in 18 years. And unlike the pivot the pivot trial, they found significant reduction in all cause of death, significant reduction in death from prostate cancer. Also, the overall survival benefit was for younger men, but they also found significant reduction in incidence bone metastasis and also in disease progression. Very interesting is this data. The number needed to treat to prevent one death is now in 8 patients. So, what do we have about comparing watchful waiting with active surveillance if you consider all types of strategies of active surveillance? This paper is very interesting because it says that active surveillance, either whatever was the strategy used, has a reduction in lifetime risks of prostate cancer metastasis, has a reduction in lifetime risks of prostate cancer death, and really we can expect a 30 to 41% of radical treatment at 10 years of follow-up on the patients under active surveillance. What are we waiting for active surveillance? As defined by d'Amico, which uses Gleason score less or equal to 6, baseline PSA less or equal to 10, and less than 50% biopsy scores, patient selection is fundamental, especially now because we are able to use prostate cancer biomarkers and new imaging studies. Clinical parameters and predictive nomograms really do not uniformly differentiate between what is a favorable prognostic risk or unfavorable prognostic risk for patients with intermediate risk of prostate cancer. And it is interesting that high-risk prostate cancer is diagnostic during follow-up under active observation in almost 30% of cases. What are the tools for diagnostic before putting a patient in active observation, before the decision of active surveillance? We have clinical staging, baseline PSA, PSA density, plus 2 pro-PSA and Phi tests. Baseline caveolin, this is a new tumor marker that came out this year. Prostate biopsy Gleason score, prostate multiparametric MRI, especially using the PRATS version 2 classification, prostate multiparametric MRI guided fusion biopsy, and also genomic analysis. Those two, Prolaris and Decifer, are extremely expensive, and probably the number of departments that are using it is very small. But they came out several papers with the 17-gene genomic prostate score, 17 GPS, sorry. Well, this GPS is very, very interesting because in patients with Gleason pattern 6, there is a very similar distribution among groups of multiparametric MRI. But among patients with GSET, the score is very different among the different groups. And it is interesting that there is an upgrading of 6.3% from the very low risk prostate cancer to the low risk, and 72% from the low risk to the intermediate risk. So it seems that this genomic analysis is able to redefine the patients for decisions about making or not making active surveillance. Or at the urological practice level, we also must think about what is the probability of indication of active surveillance for low-risk prostate cancers. Among urologists, there is a mean variation of 27.8%, coming from 5.1 to 71%. And also the rate of the concordant guideline for the kind of follow-up that those patients are doing, there is a mean variation of 26.5%. About the oncological outcomes for the cohorts under active surveillance, it is well known there is a long-term safety of these methods. The adverse radical prostatectomy pathology can be as high as 64%. The 5 years prostate cancer progression can be as high as 91%, and the cancer-specific mortality rate at 12 and 15 years can go to 3% in the low-risk patients, and can go as high as 11% for intermediate-risk prostate cancer. What are the programs of prospective active surveillance now? We have a database from Johns Hopkins, we have a database from Sunnybrook Health Science Center in Canada, and we have the Movember Foundation's GAP3. This is the bigger one, but with the lowest follow-up. And what are we expecting at 5 years under active surveillance? They have 58% of patients in low risk. At 10 years, we can see numbers of 50%, 62%, and 39%. At 15 years of follow-up under active surveillance, you can see 43, 58, 23. And the death that is expected at 10 and 15 years is really very small if the patient is from the low risk group. Because if the patient belongs to the intermediate risk group, the risk of death at 15 years of follow-up rises to 11%. There are racial disparities among untreated men known in the United States. We have seen here that 37 of untreated patients are Caucasians, 58% are Afro-American. And for those who enter in active surveillance strategy, the percentage of Afro-American patients that enters in one strategy active surveillance, 2 strategy activation, 3 strategy activation is less than half in almost of the comparisons. Are Afro-American patients eligible for active observation? We look at this paper, and it is interesting to see that Afro-American patients are much more likely to be diagnosed with intermediate and high risk prostate cancers than in low risk. Among the low risk patients, 33% are Caucasians, 41% are Afro-American. The mean age is significantly lower, the prostate volume is smaller, and the upgrade after radical prostatectomy is also significantly lower. So we can conclude that low-risk prostate cancers in Afro-American are perfectly eligible for active surveillance protocols. What about body mass index? It is interesting the distribution of men along the body mass groups, body mass index, and we see normal are 24% of patients, 61 are overweighted, and almost 50% are obese. And among the obese, they have higher age, higher prostate volume, higher body mass index, and the unfavorable prostate cancer in the transition zone has much higher percentage of presence, and the risk of unfavorable prostate cancer is 3 times higher among the obese patients. What about the age? The younger age patients are there eligible for active surveillance. This data comes from the University of California, San Francisco, in 1,400 patients with a good follow-up. And patients, younger patients with less than 60 years had a mean age of 42% compared with 58%. The Gleason score at 3 years of follow-up is 27% compared with 58%, and the Gleason score at 5 years of follow-up is 45 compared with 52. So really the younger age is completely independent associated with the less risk of biopsy Gleason score upgrade. Doesn't have any association with the risk of definitive treatment and has no significant association with the risk with recurrence. So younger patients must be perfectly subject to decisions on active surveillance also. What came out about family history? This is an inquiry to the urologists, and it is very interesting. 95% collects family history when discussing risk, when discussing screening, when discussing treatment. They recommend, the majority recommends early screening when there is a positive family history. They recommend radical prostatectomy in 52% of cases when there is low-risk prostate cancer and 1 family cancer death, compared with 80%. And 47% of urologists recommend active surveillance when there is low-risk prostate cancer and 1 family death, when compared with 91% of patients with no family history. So, this paper made a systematic review of literature about the family history, and they select 6 special papers, and the conclusions are here. It does not appear to increase prostate cancer risk of aggressive cancer, does not increase risk of prostate cancer progression. About African Americans, only 1 study showed an increased risk of progression, and they conclude that family history is unlikely to be an important factor for the eligibility of patients for active surveillance. What are the diagnostic tools we have for reclassification of patients under active surveillance follow-up? We have clinical excitation, follow-up PSA, follow-up caveolin, also PSA density, less 2 pro PSA, Phi tests, and we expect to have what? Those are the last papers that came out. At 3 years, we may have 62% upgrade for G7. At 5 years, according to those two papers, there must be an upgrade of 30 to 40% for G7. We expect 26% at 10 years of follow-up, 31% on active surveillance at 50 years of follow-up. And this paper uses a Markov model, and they found there is a 4% annual G6 progression among patients under active surveillance. Well, if the 17 GP score is applied in the populations under active surveillance and rebiopsy for reclassification, it is interesting that 23% of men makes a shift between the initial recommendation and a shared decision for treatment. And if you look to the baseline quarter, 34% of selected and persistent active surveillance at 1 year. But if you apply the diagnostic tool of reclassification with the genomic analysis, 55% of the selected patients are persistent on active surveillance at 1 year. So we have an increment of patients that can, using this 17 GPS, can still go on active surveillance after 1 year. Well, watchful waiting has also a role in the aging of men, especially in the aging of men, because the question is, when do you do the transition from active surveillance to watchful waiting? This paper comes from Sweden on very low risk prostate cancer based on Sweden National Population-Based Healthcare Registers. And it is interesting that using very long follow-up, until 25 years, 48% of patients changed from active surveillance to watchful waiting. And this is mostly a function of the age of the patient. At the 55 years of age, 10% changed to watchful waiting. At 70 years of age, 50% of the patients are now on watchful waiting. From the United States, and not for very low risk, but for low risk prostate cancers, that comes out this paper, which made a microsimulation model using the European data of the European trial, the CER data from the United States, and survival data from database from Johns Hopkins. And the active surveillance for patients for 55 to 65 years is considered as cost-effective, even up to 7 yearly biopsy rounds. But for older patients, more than 65, even 1 biopsy round implies a loss of quality, of quality of life. So the benefit of active surveillance over watchful waiting is still strongly dependent on life expectancy and prostate cancer risk. What are the conclusions about watchful waiting? The pivot trial does not prove increase in survival at 12.3 years of follow-up, but it is strongly contested because it's not considered a contemporary United States population, and it has considered as not having a statistical power. The SPG4 trial reveals a 44% increase in survival at 18 years of follow-up. Watchful waiting has more lifetime risks for metastasis and death than active surveillance, and we assist to an increased use with aging, especially in patients with higher dose of cases under active surveillance. About active surveillance, we assist with a worldwide continuous rising. We assist to use of special diagnostic tools, as we have already spoken. And the baseline biopsy upgrade risk may rise until 60%. The reclassification of upgrade risk during follow-up can go as far as 40%. Radical prostatectomy upstaging can rise until 64%, and active surveillance long-term safety mortality rate at 15 years is very low for low-risk prostate cancers, but can go at 11% for intermediate-risk prostate cancers. So I wish you a nice step as this Cambodian driver of tuk-tuk.
Thank you, Francisco. I think for the sake of time, we'll discuss later on, so I think we'll move on. And our next speaker, it's more than well known, it's Edson Pontes, and he's going to talk us that sometimes we have to treat patients. It's not only about active surveillance. So what do you think about cryotherapy? Do you think it's still a valid option? So Edson is going to show us what's his thoughts about this question. So Edson.
Before anything else, a disclosure, in our department, I don't personally do cryotherapy. Cryotherapy is done by one of my associates, my co-chair. I do refer patients to him, and I follow those patients, and I've been following the field for quite a while, and I'll let you know in a second. The second is that I feel like a lifer in this meeting. I've been here from the beginning, and Caleda Silva, Fernando has done an incredible job for urologic oncology in Portugal, and he should be recognized as the person who has brought urologic oncology from a time that I start coming here, this is 25 years ago, to a level in which we can have very good scientific discussions. Now, about is cryotherapy a valid option for prostate cancer? There's a little bit of a historical background, some of which, before I ever came to the United States in 1964, I lived in Brazil, but by one of those coincidences, when I was at Roswell Park, I met Maury Gonder, who was one of the pioneers of cryotherapy at the University of Iowa in 1964. Gonder eventually came to Buffalo initially and then moved to Long Island as the chairman of urology at Stony Brook. He's a good personal friend of mine who has died some time ago. Dr. Flox, again from the University of Iowa, based in some of the work that Maury Gonder and sons have done, started doing perineal cryosurgery. Remember, at that time, there was no ultrasound available for prostate. So they used to open the perineum, because perineal prostatectomy was done quite often, and basically inject liquid nitrogen with a huge amount of complications that you can imagine. The new era of cryotherapy started with Onick and Cohen, and some of those advances you can see here in 1993. Transrectal ultrasound of the prostate existed, and they started using transrectal ultrasound to place the needles, and of course urethral warming. Let me review with you quickly if cryotherapy is an option for prostate cancer therapy. And this is the concept of this ice ball that is finishing the end of the needle, and the overlapping ice ball with control of ultrasound gets the freezing area just beyond, but not to the point that you get in the rectum. And you can see the template that is many times used for brachytherapy, like radiation therapists know. What are the options of using cryotherapy? One is a primary treatment for localized prostate cancer. Second, patients with high-grade prostate cancer is one of the options. Salvage treatment for patients who fail radiation therapy. And lately, within the past couple of years, the concept of focal cryotherapy in trying to freeze one side of the prostate or just the area using MRI, ultrasound, preserving the other side so you could potentially preserve the sexual function, etc., and get rid of the cancer. This is something that's quite new. And this is some of the series published in the United States about the long-term disease-free survival by Ben in 2003. And you can see that you have disease-free survival if you use a PSA nadir of less than 0.5 or a PSA nadir of less than 1. And of course, depending what you use, you can get better results. And a long-term disease, biochemical disease-free survival, also another series published by Dolly, and again, with a PSA failure being over 0.3 or a PSA failure being over 1. Salvage therapy, when patients fail radiation therapy, is always difficult to manage these patients, and many of those patients still have localized disease. And I have done a significant number of salvage prostatectomies. Indeed, when I worked at Roswell Park, we were one of the pioneers in starting this operation, which is quite difficult technically. We have become better over the years, but you still have a very high complication rate, especially in the urinary incontinence. Even if you can do a perfect anastomosis, the tissues are not pliable enough for the patients to be continent, and being one of the main reasons. And therefore, some people have looked at salvage therapy using cryo, and this is a comparison between cryo and radical prostatectomy as a salvage from different published series. In green, the biochemical free survival, NAD from salvage prostatectomy, and in purple from salvage cryotherapy. And the rate of incontinence from cryotherapy has decreased significantly, which is not the case for salvage prostatectomy. And this is from my associate who does all the cryo in our department, Michael Chair. Now, what are the problems with those series that I just presented of salvage versus radical prostatectomy versus salvage cryo? First, they are single institutions, usually it's small number of patients. Most of the studies are retrospective. There are different definitions of disease-free survival in relation to the level of PSA. And of course, there is no uniform patient selection. In preparation for this particular talk, I have looked at a number of issues of more contemporary times. One of them is a paper published in the European Journal of Urology in 2009, in which they collected a very large number of patients, over 3,000 patients, and the technique used here was either liquid nitrogen and argon or pure argon. The follow-up in months, you can see 24 to 68 months. The PSA level either less than 0.1 or less than 0.5. And the biochemical disease-free survival, if the patient has a low-grade or low volume disease in prostate cancer, actually quite high, 68 and 74% respectively. And of course, in patients with higher grade disease, this decreased to about 50%. What are the complications of primary cryosurgery? And one of the things that always people were concerned in the past was a fistula between the urethra and the rectum that can be a disaster, urinary incontinence, and erectile dysfunction. The majority of those patients, because during the freezing, you basically freeze the neurovascular bundle in both sides, the overwhelming majority of those patients are impotent for the rest of their life. The patients need to know this in advance. How about salvage cryotherapy? Again, from this review in the European Urology in 2009. And 322 patients underwent treatment either with liquid nitrogen or argon, and the nadir PSA used was between 0.1 to 0.5. and 540 patients with argon, which is a more modern technique, with the same type of nadir. And you can see that the results in survival was 45% for low grade and 19% of patients with high grade, but only one study actually addressed the grades. As you know, it's quite difficult sometimes to grade a patient after radiation therapy failure. More recently, this is, what are the complications of salvage cryotherapy? And you can see 0.6% developed fistula, 6.7% incontinence with liquid nitrogen or argon, and among 520 patients undergoing cryotherapy with argon only, 1.6 fistula, 8.3 incontinence, and about 90% of patients became impotent, which is quite common with most series of cryotherapy. Recently, and this is a study that we participate in the United States, they looked at the primary cryotherapy only for high-grade prostatic cancer. And they entered 300 patients. You can see 222 patients were Gleason 8, 71, 9, and 7, Gleason 10. The clinical stages you can see here. And 122 of those 300 patients had neoadjuvant hormones before the cryo, and 136 patients had any types of cryotherapy, of hormonotherapy, either during or after the cryo. And this is quite common in the majority of the cryo series that I have reviewed. The results of that study, and you can see that biochemical disease-free survival 72% at 2 years, and 59% at 5 years. In a multivariable analysis, a post-treatment nadir of more than 0.4 or Gleason 9 and 10 was associated with progression. In other words, if the patient had cryo and the nadir of PSA was not below 0.4, this was associated with the progression in the multivariable analysis. Continence was quite good, 90%. Potency, 17%, and the rectourethral fistula, about 1.3%. How about focal therapy that has become somewhat fashionable lately, especially in patients that have low-grade disease? This is a group of 1,159 patients, and 1,111 patients underwent hemiablation. In other words, one side of the prostate where the multiple biopsies had been positive, they got the whole side of the prostate, with the idea that the other side you could preserve the neurovascular bundle, and of course in 48 patients that was focal. The eligible candidates had all Gleason less than 7, and the follow-up was 1 to 5 years. Biochemical disease-free survival was 80 to 90%. Continence was quite good because you just froze part of the prostate. The potency is difficult to get from the paper. It was around 80%. And what was interesting is that out of that group of patients, 201 patients continued with positive biopsies. And 45 of them was on the untreated side, since disease is often a multifocal disease. So I think it's kind of interesting. Recently, this paper just published in the Journal of Urology. It's kind of an interesting paper, which is kind of a work in progress, as a paper that gives us some ideas what's the future of focal therapy. It's about 454 patients with Gleason's 4+3. Among those patients that could be potential candidates for focal therapy, 64 underwent radical prostatectomy, and of course they are using fusion biopsies with MRI and the transrectal ultrasound. Out of those patients that would be eligible for focal treatment, they did mount specimens in the radical prostatectomy and found that there was a concordance in about 75% of the patients. But what means that in 25% of the patients, if we had used this method, you would have missed a disease elsewhere, which is very important. What are the recommendations from what's the European Association position on this? A radical treatment, as we all know, for low-grade disease is unnecessary. There has been an increase of focal therapy for low-grade disease, and it's understandable. Everything that we do lately goes that way. The biological concerns that the suggestion from the European Association is the multifocal nature of prostate cancer, and the practical concerns are the limitations of imaging in identifying and localizing a microscopic lesion. And therefore, to finish, let's finish somewhat with the philosophical thought of one of my colleagues, that one needs to be a little bit humble when telling patients or presenting patients with decisions that they should help them making the decisions. I bring something from one of my associates that in response to an editorial comment from the East Coast of the United States said radical prostatectomy, radiation therapy, and cryotherapy, the butcher, the baker, and the ice cube maker. So there was a merchant in the sky of prostate cancer giving praise of their wares. Thank you very much.
Thank you, Edson. I think this could really set the discussion, but we have to move on, and we'll do it later as a discussion panel also included here, and I'm just calling Derek. Derek is going to talk us now about a new part of the treatment, which is the new androgen receptor functions and new agents. So Derek, you are far too well known. I'm not going to present you, I'm sorry. You're already known, we have been here previously. Please let us know what's new and what's coming up in this exciting area.
Thank you. So, I'm going to try to be relatively brief, but I think I'd like to use a minute. Edson started and realized that Fernando had stepped out for a moment. So just to finish what you started, I think we should give Fernando a round of applause for years of work. As an international leader and teacher and role model. So thank you. All of us from the international group coming in have enjoyed your friendship for decades. We see that we age and you don't, but it's wonderful to come back to visit. So, we've heard several presentations on androgen receptors, and I have to be honest and say, Fernando is a little pixie. He plays little jokes. So the last program that he sent me had me talking before Elizabeth and before the presentations on new agents. So my slides are a little bit repetitive. I then arrived here and found that I'd been moved to the end. And so I'm going to fly through some of my slides quite quickly. So just to remind you the story of abiraterone, these are slides presented at ASCO by Karim Fizazi when he was talking about the Latitude study. And it really reminds us what abiraterone does. It lets us know what we saw before, that there is a clear role for at least bad risk disease, and we're still thinking about good risk metastatic disease. There are a whole series of new compounds that are predicated either on abiraterone or the more promiscuous newer version that's targeting specifically the function of the androgen receptor. And I think, and so we know that enzalutamide and several of its analogs have activity. Now, Elizabeth Heath asked a very interesting question early in her presentation, which was she asked about the androgen receptor variant V7 assay, which nobody is using. And I'd like to make a case, as someone who is thinking about saving money, I'd like to make a case for thinking about the fact that this may be something that should be introduced into Portugal. We've already discussed the fact that ABI and ENSA are very expensive agents. And so I think it's important just to think about whether the androgen receptor splice variants, and particularly V7, may actually be useful enough in prediction to help you making some of the decisions. We've had some very good, very practical clinical discussions about when to use chemo, when to use ABI, when to use ENSA. So let's just spend a moment thinking about this. Now, firstly, resistance to enzalutamide can occur with overexpression of CYP17. Certainly, the ligand binding domain, LBD, can have activating mutations. But what has become clear is, and the others that I've listed there, what has become clear from work done at Hopkins and at Sloan Kettering is that the V7 androgen receptor mutation is particularly useful in defining prediction of that. So one of the reasons it's important is that it's more abundantly present than other splice variants. It's constitutively active, so it can't be inhibited by ligand-binding domain targeting agents. It produces a measurable translated protein product. It's not affected by nonsense-mediated mRNA decay, and its expression can be heavily increased in castrate-resistant prostate cancer. This is from the Hopkins group, and if you look carefully, I'm not a big exponent of waterfall plots. I look at them very carefully because just the fact that it goes down, in my opinion, doesn't mean anything, but certainly it's better than going up. So if you discount this part of the curve as being within measurement error, I think you can comfortably say that this level of down measurement, more than a 50% reduction, is important. And so here you can see in enzalutamide cases, the yellow are positive, the dark are negative. You can see that positive really does correlate very well with resistance. Now, not 100%. You can see there are some ARV7 negative ones, but across the board, resistance is largely mediated by this measurable test. And it's a commercially available test in the USA. That means it could be a commercially available test here. If you look at progression-free survival, and you know I'm a big believer in looking at overall survival, so I don't want to make too much of this, but PFS is useful as an indication of what is happening at a point in time. And so what I would say to you is, if you look at the comparison of negative and positive, that's a pretty good predictive function for abiraterone. And then if you look, oops, I've lost a slide. There is a similar difference for enzalutamide. More extensive data confirming the same observation from Howard Scher. Again, look at the correlations with downward moving, in other words, reduction of tumor volume associated with absence of ARV7. That's pretty impressive stuff, even though I accept it's just showing an initial measurement. It's not necessarily about survival. Remember also that there may be some predictive value for taxane function. We tend to forget that the taxanes work at the level of microtubules, and there are some very interesting interactions between the taxanes and the drugs that target the androgen receptor. That's one of the fascinating things about the taxanes, is they're not just ordinary chemotherapy agents, and I think that's not a theme that I've heard mentioned too much here. So, if you think in terms of predictive function, we've had some very interesting cases discussed. I think it was Elizabeth that had a complex case where she was pushing us to do testing. She was asking us questions about what would you use at which point. And although she didn't emphasize the issue of ARV7, as you can see, pre-enzalutamide, post-enzalutamide, post-enza and, post-ABI, and then post both of them, you can see an increasing prevalence of this. So it really does seem to have a pretty strong predictive function. The data are predicated on relatively small numbers, but I think each report that comes out looks better. As we think through what we know, this is an example that we've talked about before today. I remind us that there isn't really a great deal of difference between continuous and intermittent therapy. As you can see, my big theme for the 2018 Lisbon meeting is to keep bringing us back to cost effectiveness. It's very interesting, and I think both Elizabeth and I, and perhaps some of the other visitors, collaborated with Maha Hussain in this Southwest Oncology Group study. And Maha presented it as a study in favor of continuous therapy. And there's no question, she's absolutely right. Continuous therapy does have frontline a slightly improved survival. But if you think about what I would call the Pontes principle, how big a difference is there between the curves? Do you really want to be having continuous hormonal blockade? We think about the sexual functions, but remember, continuous blockade, as all of you know, but we sometimes forget. Men feel worse, they have a higher level of depression, their muscle bulk goes down, their sexuality goes down. It's no picnic to be on continuous hormonal blockade, and all of us who have used intermittent blockade have seen patients blossom and improve. So just very important to be thinking about what are we getting back, both in cost-effective terms, but also quality of life terms. The more times in this study people went back on treatment, the difference is narrowed. So there's no question that after the first holiday, or maybe the second holiday, there's no benefit to interrupting. But it's just worth keeping in mind, and also worth keeping in mind as our reference point, what the median survival was. Now, one of the things that I think is interesting, the reason I've put this up, is I've been watching some kind of stupid discussion about the new agents. And one of the things people like to say is, well, if you look at the Southwest Oncology Group study, the median survival was 5 years. And therefore, there's something wrong with the ABI and the ENZA data. But that's actually not true. And so before I get to latitude in the context of this, it's already been discussed, but you'll see silly commentaries in the literature. Just remember one crucial thing that people have forgotten, and that is in the SWOG study, in order to get into a comparison of continuous versus intermittent treatment, you had to have responded initially to hormonal therapy. So there was a huge case selection bias. So the fact that we had good figures at 5 years in the continuous versus intermittent study was a function of the fact that to get into the study, you had to be a responding patient. That is not the situation with any of the other studies that I'm going to briefly talk about. So you've seen the design of Latitude, you've seen these data, there clearly are differences, but again, you will start to see editorials that say, well, not so fast, not so fast. This is overall survival rate at only 3 years, and the comparison is with 5 years. That's not a valid editorial comparison, because these cases are all comers, and the other cases are selected from the point at which they were already responding. It's a tremendously important point to make. Consistent data that you've seen. We've talked a little bit today about the side effect profile. One of the things that I did want to emphasize with this slide was to remind ourselves, when we're talking in a fairly casual fashion about the benefits of docetaxel versus abiraterone and enzalutamide, just remember that docetaxel, and I'm not speaking as a person who wants everyone to have chemotherapy, I just want to look at the big picture. Docetaxel has been around for decades, and these new agents haven't been. So we know that nothing much happens to people who've had docetaxel late. They have their side effects early. You know that there were some problems when the company introduced cabazitaxel out into the community. Someone said today that inexperienced doctors can make mistakes, but it's basically a drug that we know really quite well. Whereas these agents, we actually don't have a good sense of what is going to happen to the hypothalamic pituitary end organ axis and all the other pieces of the hormonal response domain, because these agents are by their design promiscuous. They hit a lot of different targets. So one of the other things just to remember, and we've again touched on it with the early report, and again I emphasize the early report from Stampede. This is not yet mature data. It's not yet long-term peer-reviewed data. At the moment, we're trying to make a comparison between these curves as best as we can, and we can simply say, at the present time, there is no major difference. And that was said by, I think it was Chiara who gave that presentation. So we know that these agents are useful. We know that they give some measure of survival benefit. So where does that take us now? Well, the first question that we're starting to ask is, what should we be using first? Enzalutamide or abiraterone? Is one better than the other? And there's a nice study presented last year by Kim Chi, who actually asked the question. It is an underpowered study, and so I don't want you to say there's absolutely no difference between them, but what I think you can say, and here are just the baseline characteristics, slightly older population who had enzalutamide, a bit of a difference, but not huge for performance status, but basically pretty well matched. Always remember that if you have a p-value of 0.38 with a small comparative series, all you can say is there's maybe a little bit of a trend. But having said it, hard, Edson, wouldn't you say, hard to get excited about the difference if there is one there. So reasonable to say that although they operate differently, they are really quite similar agents in terms of their utility. Now, one of the interesting things, and this is where I'm taking this, part of my job was to talk about new biomarkers. Elizabeth asked you the question, would you measure cell-free DNA? And everybody completely ignored her asking that question. I watched her closely. There were tears in her eyes because you completely ignored her, even though she was trying to draw you along that pathway. Pedro Oliveira was the only one who got excited, but Pedro gets excited about everything, as long as it's Portuguese. And so the fact of the matter is that this is kind of interesting stuff coming out of Kim's study. So again, reminding you, he was doing a simple comparison of Enza and Abby, but what he really did, and what he was really interested in, was looking at the impact of prediction if you actually measure cell-free DNA. And the answer is, it does actually matter. I've listed here, in a sophisticated audience like this, I'm not going to read every line. You can see the things that actually matter when you're looking at a series of these patients. And so my message is there are a number of new biomarkers that you can use. We actually don't know which are the best. So in Portugal, I would say look at what you have available. You've got some amazingly strong laboratories here. So you talk to your pathologists and say, what can you do and what can you do inexpensively? Remember that the genomic landscape is chaotic in prostate cancer. The more metastatic it is, the more chaotic it is. So we do know that there are a number of different pathways that are tremendously important. You've heard us talk about BRCA1. I think a couple of the talks mentioned in the discussion on the first day, the PI3K, and then we've mentioned in passing all of these other ones. To me, the most important at the moment, that may not be the case next year, but at the moment, androgen receptor amplification and mutation are the ones that I think are potentially money in the bank for prognostication. And again, to make the point clearly, when you think about wasting money on tests, remember how much money you'll be wasting if you use these new agents inappropriately. A nice summary slide here just showing you the predictive value of some of these tests, and it's not inconsequential. It's not a home run, but we are at the early stage of understanding how these measurements actually allow us to predict outcome. And when you actually plot survival, as we've done here, you can see that the level of androgen receptor gain is important. You can see that it actually does matter. If you cannot see circulating DNA, it matters. The number of mutations gained actually influence time to progression significantly, and they are associated with survival as well. That's a little harder, and that's just, I've blown it up, again, to show you more different measurements. Some of them are very simple, and we've known them for years. We've known that the anemic patient is going to do less well because many of them have marrow failure. We've known that people with high LDHs are going to do less well because it's a measurement to some extent of biomass of tumor. But the point that I would make is, I think as we evolve our patterns of oncology worldwide, and including in Portugal, this will become increasingly important to give us the opportunity to tell patients what we expect to be the outcome. When you have strong androgen receptor gain, versus not, you can see the difference in outcome. And so this is going to drive the pattern of what we do. And why am I making such a fuss about it? Again, I think it was Elizabeth in passing who mentioned apalutamide. This is a paper from the New England Journal just a couple of weeks ago from Matt Smith and colleagues. Apalutamide has been approved for treatment in metastasis-free prostate cancer. In other words, to stop metastases from occurring. Here are some of the data of a placebo-controlled trial. You can see the disease characteristics. That's a pretty big difference. But if you can look at these tumors and make a decision about whether they have ARV7 that will likely predict for this not working, it will save you wasting an awful lot of money and the patient's time. Because when you're trying to stop metastases from occurring, you can go for years on an ineffective treatment without knowing it. If you can't measure a predictor, you won't know what you're doing. So this, as the patterns of practice change and this whole echelon of new drugs become available, this will become very important. One of the things you'll notice is that I have not done the medical oncologist trick of showing you 4,700 phase 1 trials that are completely uninterpretable for all the new agents. And the reason is we simply don't know what's best. There will be randomized trials that might be mature by this meeting next year that will allow a useful statement to be made. But I see absolutely no benefit in chronicling 27 different drugs where we just don't know where they fit or how to use them. What I would say is in the new hormone domain, as more of these drugs are introduced into routine practice and trial practice in Portugal, my strong recommendation would be to start banking specimens so that you can actually use the predictive assays and start to understand how these drugs are likely to work. I think the ARV7 mutation is going to be critically important in prognostication and prediction. I think you'll find there will be some other novel determinants, as I showed you. If you can measure circulating tumor DNA, cell-free DNA, that's a bad thing for the patient. We have some new standards of care, but they're expensive, and that's the reason for using predictors. Thank you for your attention.
Thank you, Derek. I think these are amazing times, and indeed, new agents are coming, but I really think that we have left the best for last. And well, I'll try to tell you that radiation is also changing a lot. There are exciting times in radiation therapy, new ways of treating, new schedules, new doses, dose escalation, where new treatment devices. Well, everything is changing on radiation oncology. And Anthony, I'll ask you to tell us something about it,
Sure.
Okay? So let's hear it.
Thank you. I've been billed to talk about radium-223, but I've chosen not to do that. I know you're mainly urologists, and I think I've selected a few randomized trials that have come out in the last year or so that are very relevant to your practice as well as to mine. And I think there are 4 big questions that we've pretty well answered over the last few years. Is surgery better than radiation? Did radiation treatment become more accurate? Are short courses of radiation safe and effective? And does hormone therapy help post-operative radiation, salvage radiation, which we're having to do an awful lot after radical prostatectomy these days? So let's just start with the surgery and radiation question. You can't have a uro-oncology meeting in 2018 without discussing the PROTECT trial. This is a mega trial from Britain. I've been on the steering committee for nearly 20 years. It was a most fantastic effort. It was well designed. There was equal participation by oncologists and urologists. It was designed, it was big, it was expensive, but it was designed to answer questions. And when the results were published last year, I think a lot of people were disinclined to believe the results. This mega trial involves something like 500,000 patients. You know, you talk about the National Cancer Database with all its useless data, having a large number of patients, but it has nothing like the CAP Protect trial. The first randomization was PSA screening versus no screening. And I'm going to give you a little teaser. The results are coming out in JAMA on Monday. Now, I'm 59. I've been waiting a long time to know whether I'm going to do my PSA test or not. But I'll tell you on Tuesday morning, although I do know the results already. And then of those who were screened, in whom cases were detected, they were randomized to surgery, radiation with a short course of hormone therapy, or to active monitoring. And the results were pretty clear. You pay a lot of money to get a clear result. This is a clear result. Active surveillance, surgery, radiation, prostate cancer mortality. At 10 years, there is no difference, there is no hint of a difference. So as radiation oncologists and the surgeons, we have to stop telling our patients with low and intermediate risk disease, 25%, that they've got to get their surgery within the next few months or something bad will happen. Well, no, you'll be okay for a few years, but by 10 years, you'll be fine. There is a difference between treatment, surgery and radiation, and no treatment. This is progression. Now, it is possible that over the next decade, this difference will evolve, and some lives will be lost by not going to immediate treatment. But that's purely speculation. The 15-year data will come out in 2020 on the PROTECT trial. If you look at many of these progressions are not are asymptomatic. They may be going from T2 to T3 disease, or a rising PSA, or in some cases, the development of metastases. But those are few. And try and see a difference between surgery and radiation, and you just can't, nor is one emerging. There was tons of prospectively gathered data on quality of life that was just extraordinary. They were still collecting 90% of questionnaires on men 7 or 8 years later after their primary management. And, you know, you've all seen this data. GU, certainly radiation patients did better than prostatectomy patients. Sexual function, the radiation patients did do better than prostatectomy. For GI function, surgical patients did better than radiation. None of that was new. What was new was the extraordinary and conclusive quality of this data. And I can tell you there was great, immaculate quality control in both the surgery and radiation in this trial. So what do we conclude from PROTECT? Is treatment better than surveillance? Well, in some ways, yes. For low and intermediate risk disease, I think there is a small advantage, and we have to tell men. But that's, when it comes to speaking to a man who's in his 70s, I have no trouble starting them on active surveillance. And in fact, most low-risk patients at the Mass General, regardless of age, are started on active surveillance. Is surgery better than radiation? Well, not in terms of disease control, and it may even be worse in terms of some morbidities. So I'm not here as a radiation oncologist to crow about that. I'm just saying that both treatments aren't so great. So over the last decade, since PROTECT was initiated, just as surgery became better, you know, robotic techniques and improved nerve sparing and all the rest of it, so radiation has improved as well. And there have been a number of developments in the so-called radiation delivery systems. We went from 2D radiation to 3D radiation to intensity modulated radiation. And now there are all these, there's been this sort of nuclear proliferation. And, you know, for urologists, who knows what the difference is between protons and intensity modulated protons and stereotactic and tomotherapy? The truth of the matter is there probably isn't much difference between any of these. They're all just good, accurate forms of treatment. That's probably the truth. We're doing a randomized trial comparing protons with IMRT that's nearly complete. We'll finish next year, and it has quality of life endpoints. So we're trying to answer some of these technology questions. But I think it is true to say that the technology has improved, and so long as your radiation oncologists are using something that is in that basket, they're probably doing a reasonable job. And we make these lovely color wash diagrams to show how, you know, the tornado of radiation is swirling around the prostate with great accuracy. And you can make them for protons or SBRT or the various other things, and they all look the same. Radiation oncologists get very obsessed, you know, with their own technology. It's a bit like surgeons, you know, the robotic surgeons versus the open surgeons. Probably all the same. The biggest difference in the last 20 years costs about $15. And that's just putting a few little gold markers into the prostate so you can see it every day before treatment. That probably has made a really substantial difference. And it gets to Derek's point about cost saving. You know, it isn't all about a fancy new technology. It's often about the simple stuff. Some of us use endorectal balloons just to hold the prostate in place because the prostate can move from day to day. And some of us use a spacer material injected between the prostate and the rectum. And the PROTECT trial illustrated that there is more GI toxicity. That means rectal toxicity from radiation than there is from surgery. So this is an attempt to address that problem. And many of us are starting to fuse MR, which is, as you all know, is a huge part of our practice. We can fuse MR with the CT scans that we use for planning. And everything's looking very good. There's a Dutch trial called the HYPRO trial, within which there wasn't the primary endpoint of the trial, but they looked at those who were MR planned versus those who weren't MR planned, and they showed fewer anorectal symptoms. And there have been other randomized trials, not big randomized trials, but a randomized trial looking at these spacers with quality of life endpoints. And you can improve reduce rectal toxicity. Now, all of that is important to the patient, but one of the things that's very important to the patient is this notion of radiation going on for week after week after week. When you tell a patient, well, you could have surgery, or you could have 8 weeks of radiation, they often think, surgery, get it over and done with. I actually think 8 weeks makes radiation very uncompetitive. And why did we take 8 weeks over the radiation? Because in the olden days, when treatment was inaccurate, there was a lot of normal tissue in the field. So we had to take the radiation slowly for fear of late effects. Now our treatments are so much more accurate, we think we can accelerate treatment. Think is not the same as no. So we have chosen to test this in a number of randomized trials, all of which came out this year. Hypofractionation certainly is appealing for patients. It's more convenient for our radiation oncology departments. It keeps down our wait lists. And of course, it reduces healthcare costs and wait times. So this is a US trial, US and Canadian trial, 1,000 men randomized to 8 weeks of treatment versus a more accelerated form of treatment, 5.5 weeks. The bottom line is there's no difference in treatment efficacy. This is a PSA endpoint, by the way. And there's a fractionally higher risk of grade 2 rectal toxicity, but quality of life studies showed they were identical. So 5.5 weeks is safe using modern techniques. In Britain, of course, they always push it further. They ask the good question, and then they answer them with huge numbers of patients. 3,000 men, mostly intermediate risk disease, 4 weeks, 7.5 weeks, or something even less than 4 weeks. And this was reported in Lancet Oncology. Efficacy, all the same. If you accelerate the radiation, you get the acute morbidity a little bit earlier than if you take, it comes in at about 3 weeks rather than 5 or 6 weeks. But late toxicity was identical. So Britain has switched over completely from 8 weeks to 4 weeks. Now, in the United States, and I hate to say this, but I'm going to knock my own country, where radiation oncologists are paid by the treatment. We earn twice as much for 8 weeks of treatment as we do for 4 weeks of treatment. I can tell you there hasn't been quite so much enthusiasm for the shorter treatment. All my patients are treated in 4 weeks. And if we can do it in 4 weeks, could we do it in 1 week? Really accelerate things? Well, the answer is maybe. We don't know, but luckily the British have tested this. And this is a trial comparing 1 week of radiation against prostatectomy. This one is accruing very badly. They've only got about 70 patients in that arm. It's been open for a few years. But this trial, standard radiation versus 1 week, closed in January with 850 patients. First results 2020. So we're introducing new technologies, and we're asking the questions: are they better, and how can we manipulate them for the benefit of our patients? So is hypofractionated radiation safe or effective? Yes. 4 or 5 week schedules should become the standard of care, and 1 week schedules may become the standard of care in the future. I don't know yet. Let's wait for the trials. And then finally, something very relevant to you guys. You send us an enormous number of patients with rising PSAs after prostatectomies. It's just the way it is these days. And in 1996, this trial, RTOG 9601, was set up. It shows you how long you have to wait to get the results of a prostate cancer trial. So it's finally reported last year, 21 years later. 760 patients with rising PSAs were randomized to salvage radiation alone, or salvage radiation plus, you'll say, what's this about? Bicalutamide for 2 years? Well, the company were prepared to give us the drug so we could give it to patients for free. It seemed like a good idea in 1996, not such a good idea now, but you know, hormone therapy is hormone therapy. And now, presented at ASCO 2 years ago, and now it's in the New England Journal, there actually is, by 15 years, a small survival advantage. It's a small survival advantage. It's not huge. This is overall survival. It's not huge. So I don't believe men have to have hormone therapy with their salvage radiation. Certainly if they're in their 70s, you know, it's debatable. But it certainly is there. Now, would we give all patients being treated with salvage radiation hormonal therapy? Well, we've done subgroup analyses according to the various stratifications that we used in the trial. And it's hard to say exactly who benefited. It seemed that the majority of patients benefited, though many of these lines crossed one. So we tend to give hormone therapy with salvage radiation if patients had a PSA of more than 0.7, or if they had high-risk disease. And we obviously don't give them 2 years of bicalutamide. That's ancient history. We give them 6 months of an LHRH agonist. Now, whether this is the same, we don't know. There's a French trial, the G2 trial, that suggests that it is, but we don't know that yet. So what have we learned in the last year that's kind of relevant to you guys? We've learned that many patients with low-risk disease do not need treatment, and I think active surveillance is what we should be offering them. And that's what we do at the Mass General. 70% of our patients with low-risk disease do active surveillance. I think it's tough to tell patients that either radiation is better than surgery or surgery is better than radiation. The trials don't support either of those presumptions. They seem to be equivalent in efficacy. We do know that just as surgery has improved, radiation has become more accurate, and we've actually demonstrated it in small randomized trials. We've demonstrated in large randomized trials that radiation can be made shorter, more convenient, and more economical. And you should consider adding hormone therapy to salvage radiation. So I'm going to stop there, because that's all we know in 2018 as radiation oncologists. Thank you.
Thank you, Anthony. I'm calling now Fernando and Pedro. Pedro Nunes, thank you, to the stand here. And I think we could start the debate, okay? So any questions to the audience? I think you are here, Pedro.
Edson, can you give me a good reason why you would choose or send a patient for cryotherapy?
I don't send patients for primary cryo because I think they will become impotent. I think it's maybe good control, but probably not very good quality of life. I think there is a place for cryo in patients that have failed radiation therapy. I have personally done a lot of salvage prostatectomies, and I'm quite good with it, but I still have a significant percentage of incontinence, and that's related to the pliability of the bladder neck. I can put people together, but they just don't work. And therefore, I think it's a very viable option of cryo. So I usually send them to Michael Chair, who is excellent in putting those needles in the location and so on.
Another one?
Anthony, Brian back here. A similar tone, I guess. Can you give me a good reason why we should use proton therapy for prostate cancer? In the United States, it costs quite a bit of money, over $100,000 at MD Anderson. Image-guided radiation therapy pays $30,000 from Medicare. And markets it as, you should be pleased you've gotten cancer because you have the opportunity to have proton therapy now.
I can think of absolutely no reason why a man should have proton therapy. It's one of the great tragedies of American medicine, that particularly the world of prostate cancer, that we've been sort of overrun with gadgetry and wizardry, much of which has been marketed ahead of evidence. Whether it's And proton beam was one of the first of these to be heavily marketed. So we've spent 20 years studying proton beam, and after 20 years of study, I can find no advantage. I'm totally comfortable putting my patients into our randomized trial of IMRT versus proton beam, but I won't treat patients off the randomized trial. We've got 300 patients randomized. We're going for 400. And then there'll be a quality of life endpoint. It's entirely possible that the proton patients may fare worse. There are some biological reasons that we've recently discovered. So I'm not going to predict how that trial is going to end up.
Very good. Edson?
I'll ask a question. Okay, please, I'm sorry.
No, I was going to ask, Edson, I was going to ask you a question. And now that HIFU has been approved in the United States for radiation failure, can you think of a reason why I wouldn't use that instead of cryo?
I think it's a preference. We do a huge number of cryo at the Karmanos. We have just published an experience that's going to put us out of business for small renal tumors. We have just got over almost 400 cases that we have small renal tumors with the results that are exactly the same as in relation to recurrence and so on as renal sparing surgery. And it's done as an outpatient and so on. So there is a heavy influence at Karmanos from cryo instead of HIFU. But I have a question that I truly, those so-called heavy particles. Years ago, one of a very rich patient donated a neutron with the conformal radiation therapy in Detroit. It was one of the few. Neutron had a terrible reputation because they used some of the NASA neutrons. It was terrible. But we did have our own cyclotron. We had a machine that did conformal radiation, which now probably millions of dollars that not being used. What's the difference between proton and neutron?
And carbon ions and helium ions. They're just different particles. They're just different ways of delivering radiation. They can be controlled in different ways. They deposit their radiation differently. It's sort of a debate for the physicists. It's the radiation oncologist's equivalent of a theological debate about how many angels can dance on the head of a pin. There are some biologic reasons why carbon might be better than protons, and there's some biological reasons why protons might be better than neutrons. But they are fine detail.
Okay, and Anthony, do you think, you stated very clearly that we are just on the verge of having the first solid results on hypofractionation, right? So that's very appealing for us because you are really shrinking the size of the treatment. But do you really think that we are ready for one fraction because there's a lot of fuzz here in the country
Oh, yes.
around that. Because outside of a trial, do you really recommend one fraction for prostate cancer?
No. I mean, the problem with radiation is there are acute effects and there are late effects. And late effects occur, I mean, you guys have to deal with our late effects. You're the ones who are up in the middle of the night irrigating bladders, which are full of clots. So those late effects keep on coming. And if we study those of our patients who we've treated with high-dose radiation conventionally, there are patients who are having their first episode of hematuria 12 years, 13, 14 years later. So very premature data with just 1 week of treatment or 1 day of treatment, not outside a trial.
Thank you, Anthony.
Can
Any
I
question?
just-
Pedro, yes.
I just want to ask Derek a question. When you are not able to measure the circulating DNA to assess the androgen receptor splice variety, how you do it? Do you still do are you still using the drug? Do you stop the drug till you can evaluate it?
I think that you use the drug routinely without any of these tests. What I was saying was these tests are now available and they will improve the precision of use of the drug. So I wouldn't change standard practice in Portugal today. What I was saying was if you think about where to spend some money wisely, developing a battery of tests in this space, particularly as Spain and Portugal both have very strong clinical pathology, chemical pathology, and translational science, you're very well positioned to do it. And if you remember, Pedro, I made the point that what I would advise the people here to do is to talk to their pathologists and say, given that you have established technologies in your labs, which of this array can you do easily now? Because like Anthony, I don't know which is going to be the best. The androgen receptor V7 is the most tested. We are looking at cell-free DNA, and there it's pretty non-specific. I mean, cell-free DNA that you can measure just tells you there's more cancer around somewhere in the body than if you can't measure it. That's all it tells you. With the passage of time, as we develop new techniques for looking at the circulating tumor cells and studying them, that at the moment is hard to do. So the Johnson & Johnson self-serve technique that you know very well messes up the cells outrageously, so it makes it very hard to get an ARV7 measurement on those. Richard Cody has developed some cell sieving techniques, where it's like having a sieve that you put wine through. Those cells are less damaged. So my answer to your question is I don't particularly care. I think if the purpose of this meeting is to let a very sophisticated audience get a sense of what direction to go, Anthony has told you some things that I think make perfect sense, that say there aren't differences, there are differences in certain areas. My point here was simply to say this technology, I think, predictively will be useful. Now, I have to say, about 10 years ago, I said I thought P53 would be very important in bladder cancer. I tested it. It turned out to be less important than we thought. So the fact that I'm predicting it doesn't mean a thing.
Amazing table that we have here. I have a question for Dr. Pina about active surveillance. It was a brilliant exposition, and we all know that low-risk prostate cancer is very common. And I eager offer active surveillance to my low-risk patients, but I don't have that much acceptance what I'm doing wrong. On the other side, some of us in a couple of months will be in jail for operating some Gleason 6 prostate cancers, but I see every week Gleason 6 prostate cancer with metastases, some of them dying of them. What are we doing wrong? Is it mandatory to perform a template biopsy and an MRI multiparametric to all the candidates to active surveillance?
Well,
We don't know.
let me
I
say-
feel I'm doing something wrong because I can have huge numbers of active surveillance. Are Portuguese people different from the other countries, or the problem is
Portuguese-
in the urologist
Portuguese
community?
people is very different from region. We know that from data from mortality. First. Second, in the region where I practice clinical, until 2013, that are the data we have, the number of patients with low risk prostate cancer was really low. We had 6, 8, 9% of patients G6 with low risk. So it is interesting that we can see the delivery of brachytherapy to so many patients around. This is the first set. Then another set of ideas is that if you look to the temporal trends we are seeing in patients in the north of Europe and also in the United States, most probably those numbers don't have been arrived with the new armamentarium we have now. Because before the use of FIT tests, we had in St. John's Hospital a rate of 35 positive biopsies only. In my private clinic, I had the same numbers. Now, with the use of FIT tests, which we don't have in official hospitals, but we have them outside, the number of positive biopsies with important cancers are completely different. We can reduce the number of patients to biopsy. The first item is this one. And the number of significant cancers we can catch now using FIT tests and also the multiparametric MRI are completely different. The panorama is completely different. So I agree with you. In this moment, I don't put anyone in biopsy outside the hospital without a multiparametric magnetic resonance. That's my position.
Can I just add that in the PROTECT trial, active monitoring was done without MRI. It was just PSA and a rectal exam. And those patients did pretty well. But I agree, we bake an MRI into their follow-up protocol. I will say, talking about the personality of patients, it used to be said that you couldn't possibly persuade an American male to do active surveillance because they're action men. And that's
You
turned
are
out
Mediterranean. We are even worse.
you're even worse. It's turned out to be completely false. In our multidisciplinary clinic, a surgeon, a radiation oncologist, a medical oncologist, we go in and see the patient together. If all three of us tell the patient that actually what we do is active surveillance, the patient say, great, thank you, see you in 6 months.
I make a comment. For me, I have a number of patients in active surveillance. One of the most effective tools that I use, one of the charts that you made with the people, with the men, and I think that's very effective. When the patient looked at the number of people and so on, he said only 1 or 2 people that, they start accepting it. This is my tool that I use quite often.
Yeah, I forgot to talk about the reclassification of patients during follow-up. Active surveillance is a very time-consuming matter. So I don't see many Portuguese urologists working with active surveillance, using at least the three normal baseline methods we have to use. One thing is to look for PSA, another is to look for digital retinal examination, another is to perform a biopsy in a very straight protocol, and the other is to perform a reclassification with the 3 panels. So,
Dr. Pedro, is there any Gleason 6 metastatic prostate cancer?
They are wrongly diagnosed by pathologists.
I have to butt in.
And they
The
just
answer,
review
the answer
the
from
plates
this
after the
medical
metastasis.
oncologist is a
Oh,
yes.
Elizabeth.
I have two Gleason 6s that are metastatic. But I agree, it's just probably they didn't get the right biopsy. But yes, they're quite aggressive.
After the metastasis appear, they will.
There you go. I do have a question for Anthony, though, because one of the things that's plaguing a lot of medical oncologists and urologists is when do you want to see the patient with PSA rising disease?
You mean after surgery?
Correct.
Well, I want to see them as early as possible. When that PSA first goes up, and we'll have a discussion about whether they really need radiation or not. Some of these patients are 10 years out from surgery, slowly rising PSA. They're in their 70s. They don't. And other people are much younger and do. And if they do, we might as well give it to them as early as possible. I'm sure over the next couple of years, the flucyclovine PETs and all these other more sensitive scans are going to come into the picture. But we're not exactly sure of their specificity just yet.
Is 0.2 your starting number?
Yeah, but I've started below that, but generally it's around 0.2.
Do you think that 10 years is enough, or we should wait for more years? Because for the results, to have extraction to your answer, which is better. Because 10 years, I think that even if you take water,
yes,
it will have the same effect.
I think you're exactly right. But the PROTECT trial is going to publish 15-year data relatively soon. I will tell you, there isn't even a signal, of a difference at 10 years.
Some epidemiological studies from Scandinavia with long-term follow-up, after 15 years, the curves start to show a difference. So when you are, addressing a patient, and before you were addressing patients with 70 years, now you are addressing patients with 50 years, and because of the long-term survival, you are expecting it to survive more time.
Yes.
So we need to wait.
We
need to wait more time.
But those Swedish studies contain patients who were not screen detected. The screening gives you a 7-year lead time.
Exactly. But, even from the results from the Rotterdam study have shown that with time, things begin to change. But it takes time. And there is a problem in the Scandinavian studies. Many patients were diagnosed by fine needle aspiration cytology, which was not the good method for diagnosing prostate cancer.
I think there's a question. Francisco, over there.
I just wanted to add a piece of information. The SPCG for the Scandinavian trial we're talking about, there was a published report about the subclassification of patients, and in the low-risk patients, after 23 years, there were no mortality difference for the low-risk patients. So there is a global difference for all the patients, but for the low risk, after 23 years, there is no risk mortality. There is a different risk of metastasis.
I'm sorry, you didn't talk about radium for any reason, or?
Oh, there's just too much to talk about. Another systemic therapy, good for bone metastases, reduces pain, small survival advantage. Look out for the bone marrow. That's it.
Next year.
Okay. Any more questions? I think we are about to finish. So, thank you all. Just 1 second.
Just one question. Anthony, you have not talked about radium 20, about radium. What do you think about treating patients with radium 223?
Oh, I just mentioned it. I mean, it's one of many drugs that has its place in metastatic and particularly castrate-resistant prostate cancer that offers a small survival advantage and some palliative benefits in patients with bone pain. So I don't want to do it an injustice, but compared with the very interesting biology that's coming out and the new drugs that are being developed, I think it will have a place in the future, but probably not a very big place.
Okay. Thank you.
closing remarks about the low-grade prostate cancer, about surveillance. Several years ago, when surveillance was not very popular, I saw a patient in consultation from Ann Arbor, Michigan, which is not common in Detroit. Ann Arbor is a much bigger university. Not from Michigan, but from St. Joseph Hospital, of a man who was 76, who someone did a biopsy on him. And at that time, they still talk about Gleason 5. So he comes to see me because someone had proposed to him to have a perineal prostatectomy. This man had had bypass surgery. He had, he was a diabetic and so on, so on. So I talked to the family and talked to him, and I said, you know, one of the options realistically is that we just follow up with you, the chance and so on. So I wrote his physician a note. Next thing I know, this patient progressed. Obviously, the biopsy at the time was not very good, with metastasis, and the family sued me. Okay? Now, in Michigan, there is a panel of people who look if lawsuits should go forward or not, and they drop it. But my point is that the sampling, as you pathologists know, can be very important if you try to get someone in a surveillance protocol, especially young people. This guy was justified, in my view, because of his comorbidities. But those type of things happen in the States.
Okay, any more questions? So I think it was a great session, great talk, great discussion. Thank you all, and we'll be meeting in the posters. Thank you.